The pain disorder patient is a big issue. It's an issue which occurs because pain disorder is often associated with low back pain. The estimates range anywhere around 30% of all the backs you see will have elements of pain disorder associated with it. The problem is that it has a very significant impact on the outcome. It is rarely an independent condition. It's mixed together, so patients become patterns 1, 2, 3, 4, and pain disorder. We call it pattern 5 simply because that's an easy way to keep the numbers going. So you get a 1, 4, 5. That's a patient with a back pain, a leg pain, and a pain problem in addition. It's rarely independent. It is a major consideration, and it's where pain and the behavior associated with pain becomes in itself a significant problem. Now, there's lots of physiology, and I'm not going to get into that. If you want it, I've even got it all here, but there's changes in the nervous system. It's real. I think the one message that has to come across is that this is not a make-believe. This is not I'm deliberately exaggerating. These people are in trouble. They're in serious trouble because their pain basically dominates everything they do. When you listen to their histories, pain is the thing that drives them. They have mechanical problems, and as you remember from yesterday, the axiom is deal with the mechanics first, but that's first. That isn't only. You deal with the mechanics, and then you must address the issue of pain behavior. The name, the terminologies matter. The question yesterday was fibromyalgia. If you go way back in the literature, it used to be called psychogenic pain. That's no longer politically acceptable because that implies a volitional component, which it isn't. It was called, still is, by some myofascial pain, which is a stupid name. The myos and the fascials are all hurting, whatever they are. Regional pain, because it's not dermatomal, it's not in the way associated with nerve referral. Half my body hurts. That just isn't an organic situation. Chronic pain syndrome is what we still call it. I don't like the term because it's not necessarily chronic. Patients can be set up for this, and the pre-existing conditions can be that within weeks, days, these people can develop a pain disorder. So it's not always chronic. Fibromyalgia is just another name for the same thing. The problem with fibromyalgia is it takes on a life of its own. If you go on the web and look up fibromyalgia, you will find websites that don't support patient recovery, they support fibromyalgia. It's a self-sustaining injury. And I can say that because it is, after all, Toronto's gift to the world. It was a Toronto rheumatologist that created the disease, and he was actually my clinician when I was a medical student, so I've known fibromyalgia since forever. It used to have 12 points, then it was 18. I don't know where they've gone to now, but they keep... And you'll see in a moment that it really doesn't have anything unique about it compared to all the other types of pain disorder, chronic fatigue syndrome, We're all going to come back to the same place. It's pain-focused behavior, and if you want to be really up on the jargon and current literature, it's called pain disorder because that's essentially what it is. It is the plasticity of the nervous system that allows peripheral sensitization to sensitize the nervous system, and that's what it is. It's all about what you actually feel. And Joe talked yesterday briefly about the gate theory, and it goes on and on and on, but take as given that this is real. This is not something imaginary. How do you recognize it? That's the issue. How do you pick these people out? Until, if you do it the old way, you treat them for 6 months and they're not getting better, and then you say, oh, I think it's a pain syndrome. The problem is, and we'll stress this point, if you treat them and they don't improve, you are making them worse. In this world, you cannot stand still. The analogy that I use is a canoe paddling up against the current. You rest your oars, you rest your paddle, and the canoe doesn't stay in one place, it goes backward. If you treat the chronic pain patient, the pain disorder patient, and they don't get better, you're actually feeding into their pain behavior and you're making them worse. So you need to recognize the sooner you get to them, the sooner you change your approach, the better your chances are of making them better. How do you recognize them? Well, start off with the things you hear. Listen, it's history all over again. The patient that says, you're the first one who's ever told me anything, or even better, you're the first one who's ever cared about me. You're the nicest therapist I've ever met. And then you're going to hear, and that last jerk told me it was all in my head, which is what will happen when they go to the next clinician and you become the last jerk who told them it was all in their head. The one that scares me. You're my last hope. I've waited 10 years to see you. You're my last hope. And this is the one you really don't want to know. My doctor told me you were. This means the doctor doesn't like you very much, and he's dumping on you. I have a very high pain tolerance. You hear it over and over and over. And then, of course, all together, we recite, all I want to do is get better and go back to work. Now, the thing to recognize is these people aren't liars. They're telling you the truth. They do want to get better, and they do want to go back to work. They don't want to take responsibility, and they don't want to go back to the job they had. So you tell him he's lying, he says, no, I'm not, but what you heard and what I said are not the same thing. Recognize these people are genuine and their behavior is disabling. We published this 10 years ago. This is the basis that we use for recognition. There are 15 of these points. They're in your notes. I'm not going to spend a long time with it because we don't have the time. But these are the things you hear in the history. The patient that needs excessive help with personal care. I lectured to the Canada Pension judges years ago. They gave me a case book of cases. They have a man in Nova Scotia had at that time who had back pain. This is not a paraplegic, quadriplegic, back pain, whose wife had to brush his teeth because the weight of the toothbrush was too much and it made his back hurt. Now, this is a man with real disability. It's not organic in the sense that it's not physical, but it's genuine, and these people are in trouble. They blame somebody else. Listen for it. It's not my fault. I didn't put the banana peel on the floor. Their pain is constant. This is a pattern, just like any other, but it's a pattern with constant pain. Pain's totally intermittent. I rule out very quickly a pain disorder patient. They demand a physical diagnosis. Be careful. They want you to tell them what's wrong. Tell them that it's in their head. Tell them it's psychological. Tell them it's a pain disorder, and they're gone. They want you to tell them which disc it is, which ligament it is. They want a physical cause. Therefore, when we talk to them, talk physically. Don't talk psychologically. We'll come back to that. Their symptom array gets worse. You read the insurance files, this thick. Started off with a rear end accident, neck pain. You're treating him for his sore knees. How did his knees get hurt? Well, because, says the mechanical therapist, the imbalance of his head caused his thoracic spine to twist, which loaded his pelvis. No, it's not. It's central sensitization. They're getting comp in most cases. They have a high reported level of previous activity, my personal favorite. The people that have been injured for 3 months, well, before the accident, I used to rollerblade to work, and I lifted weights at lunch, and I used to jog around the office to keep myself fit. I had a guy that weighed well over 300 pounds who told me that 3 months earlier, he'd been the goalie in the national Canadian field hockey team. Now, I don't know how he gained so much weight in a hurry, or he was always that heavy, and they wheeled him into the goal, and there would, They've involved a lawyer, a rep. They're not happy with the situation. They've seen many people and will continue to do that. Their life has gone to bits. They're unhappy with their wife. They're unhappy with their job. They're unhappy with their friends. They do poorly with medication, but they keep taking it. And the conversation goes, you're taking a lot of Percocet. Yeah, I have a lot of pain. Well, does it work? No. Well, then why are you taking it? Well, I have a lot of pain. But does it work? No. Well, then why are you taking it? And you just keep going around that bush as many times as you want. Sexual dysfunction is very common. It's a way to distract you from the pain focus issue. When you start talking sexual dysfunction, everybody gets giddy and they hide in little rooms and they discuss sexual dysfunction, and you've lost the point. The point is this is part of a much larger complex. They sleep poorly. This is my screening question. When I do a patient assessment, the question I will always ask is, how do you sleep? How's your back pain let you sleep? If the patient says, well, I use a lumbar, a night roll, I get all set, I'm okay, that's not a pain disorder. These are the people that haven't slept in 6 months. When did you sleep last? 2 years ago. And of course they do sleep, they just don't sleep at night. They doze during the day, they have non-restorative, non-REM sleep, and this makes them worse. The pain goes on. They're unemployed. Well, who would hire somebody like this? And they get worse when they should get better. We took these 15. We ran a statistical analysis. Here are the top 5. And this is the thing to take home. They're blaming somebody else. They're getting comp. They're talking to a lawyer or a union rep. Their negative family situation is gone. These have got little asterisks in your notes, so you'll pick them up. And they sleep poorly. Now, the statistics here are really spooky. If you have these 5 in one patient, think about the patient. I was in a rear-end accident, and it wasn't my fault. The bastard hit me from behind. My lawyer said my comp isn't good enough. My wife's mad at me because I'm no fun with the kids, and I haven't slept in a month. Heard that story? That's a pain patient. 5 points in 5 sentences, and you can stop worrying. Oh, is he a pain patient? He's absolutely a pain patient. 3 out of 5, 82%. 5 out of 5, it's a certainty. This guy is a pain patient. That's how quick we should be able to make this diagnosis. Not after 6 months of, he's not getting better, I don't know why. Listen to them. This is, you've heard this for 2 days now. It's the history that tells you what's going on. History takes precedence. The Waddle signs. Everybody gets involved with the Waddle signs. Well, by the way, it is Waddle, like a duck, not Waddell. Gord is a Scotsman, and his proper pronunciation is Waddle. So the Waddle signs, we've modified them a bit in our usage. They come in pairs, 3 out of 5 pairs. It's not, these are considered the same. Superficial tenderness, non-anatomic tenderness. My God, that's fibromyalgia. They've got funny places that hurt when you poke them. Of course they do. They're a pain disorder. The simulated tests, where you rotate the pelvis and hold the arms down, and it's actually the hips moving, not the spine, squeezing the top of their head and saying, tell me when this hurts, and, oh my God, my back. The SLR discrepancies, which we talked about yesterday, sitting with one. This is one that we use a lot. I like this one. This is double SLR. It works on the theory, and I don't want to spend a long time on this, but single leg lift, if I anchor the pelvis, I showed you that with a straight leg, it limits your straight leg lift. So that the true sciatic patient has got better elevation with 2 legs because it rolls their back. The pain patient has half as high. Why? Because if 1 hurts, 2 hurts twice as much. And it really is fascinating to lift both legs at once, and they scream at 10 degrees when they could let 1 leg go to 50. And then finally, the cogwheel release, which is voluntary, and the sensory disturbances. The Waddle signs are important only as physical confirmation of history. That's where they work. And the same as anything else we've just done. Take a good history, get the 5 points. If they've got Waddle signs, that's confirmation. If they don't, I don't care.